Escitalopram is the most selective inhibitor among the selective serotonin reuptake inhibitors. That is, it practically does not affect the noradrenaline system, the dopamine system, or the histamine system. As for its effects, what effects can we observe when taking this medication? First and foremost, it has a mild thymoleptic, that is antidepressant effect. The person themselves may not even notice when it starts to work. Its action unfolds so gently and gradually. However, they may often find that those around them start to notice the effects of the medication. People might say, "You've become calmer, more cheerful, more optimistic. You react differently to things you previously reacted to inadequately." Although the person might say they don't see any changes yet, the effect of the medication expands in a certain way. Initially, the person changes their attitude towards work, daily activities, and certain people. But gradually, without noticing, it expands to the surrounding world, to people they meet on the street, to, for example, watching the news, to other information, and gradually it starts to change their attitude towards the world around them. It's important to note that the medication has a stimulating component. And it is precisely because of this stimulating component that the medication can cause initial anxiety, an exacerbation of anxiety. That is, the medication itself has a good anti-anxiety effect. This is probably its main point of application. But since it has an activating component, it can initially cause anxiety. And this often confuses people. They might say, "What have you prescribed me? My anxiety has only gotten worse." But this is at the initial stages. Later, its anti-anxiety effect unfolds. But it acts on anxiety, it's important to note, but not on fears. This medication cannot affect fears. It can only affect fears if they are secondary to anxiety. This medication relieves anxiety, tension, and similar symptoms. Naturally, in the presence of anxiety and tension, a person's worries and thoughts will also be anxious. There will be an expectation of some unpleasantness. And once this anxious foundation is gone, the unpleasant thoughts that arose from this anxiety also disappear. A person's reaction to negativity changes. That is, if someone offended them, said something rude, or if they saw some injustice directed at them, whereas in the past they might have reacted, now they start to take it more simply. Thoughts become calmer, the person becomes more harmonious, their thoughts and inner experiences become more aligned. They start, which is very important, to feel or be able to feel joy. And they start to derive joy from everything. As we said, it might start with one thing, and then the effect of the medication expands. They start to feel joy from food. Before, they just ate to satisfy a physiological need. Now they derive pleasure, they derive joy from work, from any activity. Previously, they might have just done the laundry or washed the dishes and felt some aversion. Now, not only do they feel neutral, but they even derive pleasure from their work. And gradually, this joy starts to spread further to the surrounding world. The person goes outside. They see, for example, gray or yellow fallen leaves, and they find joy in them. They breathe in the frosty air, and this air seems very fresh to them. It also lifts their mood. They see a dog running by and they notice something cheerful, something good in the dog. They start to notice something positive in people. Then self-confidence appears, decisiveness appears. And this arises because they are naturally not bothered by what others think of them. That is, this emotional, anxious component disappears. The person is not worried about someone else's wrong opinion. And from this, these qualities appear. Then various complexes weaken or even completely disappear. Where the person felt constrained, they now feel relaxed and free. For example, when a young man meets girls, And in general, anxiety often arises between the sexes, even in healthy people, especially in the young. This anxiety disappears when a person communicates with a large number of people or when they find themselves in unfamiliar groups. The anxiety disappears and naturally they can behave calmly in this environment. Naturally, with the decrease in anxiety levels, sociability increases, mood swings are eliminated, and as a result, the person is less likely to have outbursts. Then various autonomic manifestations decrease or even disappear. In particular, for example, the hyperventilation syndrome decreases. Therefore, this medication is quite suitable for people suffering from panic attacks. As a result of all this, overall well-being improves. Sleep normalizes, although it can be the opposite. It can be disturbed, especially in the initial stages when there is initial anxiety. What are the indications for this medication in this regard? On one hand, it is depression, but usually it is depression accompanied by an anxious component, when there is a depressive anxious syndrome. That is, for apathetic depressions, this medication is not very suitable. Secondly, it is a pure anxiety state. Its most diverse manifestations. These include panic attacks and social phobia. It's clear why. Because anxiety disappears, self-confidence appears, and naturally the person feels more comfortable in a social environment. It is also various obsessive-compulsive disorder. It is to some extent post-traumatic stress disorder. That is, any anxious manifestations can respond well to treatment with these medications. But it is important to note, if we are talking about anxiety disorders, the medication works better on patients who have just become ill, who have just started to show symptoms. But the longer, the more chronic the course of this anxiety, the longer the medication will take to unfold. That is, the more prolonged the treatment should be and the higher the doses should be. It is also taken for a number of not entirely direct mental disorders, for example, in premenstrual syndrome, menopause, post-castration disorder, and various psychosomatic disorders, and in many other various somatic diseases. But these are already specific cases. What side effects are observed with this medication? Well, it should be understood right away that everything we will list occurs in a rather mild form and arises quite rarely. That is, in principle, this medication is one of the most easily tolerated medications compared to all effective serotonin reuptake inhibitors. This medication may have initial anxiety. Like any anxiety, it manifests as muscle tension, trembling in the hands, an inability to sit still. Various psychosomatic complaints. For example, depersonalization, which perceives what this manifestation is, why it arises. In particular, it can arise due to an exacerbation of anxiety, the same tension headache, or the same asthenia, and at the same time, when this initial anxiety can last the first weeks, but most often for a few days or even disappear on its own in one day, even without coverage. Well, of course, if it cannot somehow reduce itself, then it is necessary to cover it with anti-anxiety medications. Well, many of my colleagues, and this is probably correct, generally prescribe escitalopram and immediately add anti-anxiety medications for the first 2 to 3 weeks of taking it, while there is a likelihood of exacerbation of anxiety or its occurrence. They cover it with anti-anxiety medications. It is also necessary to consider to dwell a little on asthenia, why it arises. This is quite important. I will explain why. The fact is that with a lack of serotonin, muscle tension arises. When there is insufficient serotonergic inhibition of the muscles, when muscle tension arises, heat appears, energy consumption increases, and when anxiety goes away, asthenia also goes away. That is, this is a not insignificant question, and here it is important to distinguish asthenia from apathy, because apathy will be the opposite of anxiety, while asthenia is a component, a part of anxiety. So the next side effect is apathy. And if anxiety activates us, then when anxiety goes away, activation disappears and apathy arises, which the medication can stimulate. Sometimes when there is no initial anxiety, apathy arises from the first days of taking the medication. What manifestations of apathy will there be in this case? The person starts working, does what they have to do, and once they get into it, the work flows. But as soon as the person stops working, that's it, and then it's very difficult for them to get going and make themselves work. Not because they lack strength, but because they lack motivation. They can't somehow get themselves into a working mood. They don't want anything. Sometimes they don't want anything because they imagine difficulties in achieving something. But here they don't even want anything. It's hard for them to imagine what could bring them pleasure. They can't think of any activity or action that could bring them pleasure. Naturally, in this context, there is a constant desire to sleep. But if the person doesn't go to sleep, doesn't go to rest, and starts doing something, they won't fall asleep. As soon as they lie down in bed, close their eyes, they can sleep for days if apathy has developed. A certain laziness arises, and the person is not only lazy to do something, but even lazy to plan. After all, how often does it happen? We plan a lot of things, and then when it comes to it, we don't want to do anything. For example, we think on Friday or on the weekend or on holidays we'll do this, that, and the other. But when Friday comes, when the weekend or holidays come, we don't want to do anything. So here they don't even want to plan any activity. And not only work activities, which make us exert ourselves, but they don't even want to plan rest, walks, or any entertainment. Even that causes discomfort and displeasure. They want to stay at home, not see anyone, not talk to anyone. Well, in principle, apathy won't last long. It's transient. And somewhere, it lasts no more than a month. And it should be concerning when it lasts more than a month, when it's present. Then something needs to be done about it. And what can be done first? Reduce the dose. With a reduction in dosage, apathy will go away. And another thing, if it doesn't help, you can use some activating medications and normotimics and some antipsychotics, for example, aripiprazole. And from normotimics, lamotrigine can work well here. For example, if a person is taking 20 milligrams of escitalopram, a fairly large dose to cause such an apathy syndrome, we can add 100 milligrams of lamotrigine, and these 100 milligrams, well, these are approximate doses to understand the order of numbers, and on, for example, lamotrigine, the level of apathy can decrease, and most often it does. Next, intestinal disorder, gastrointestinal disorder. Well, we know that the largest number of serotonin receptors is located in the intestines, much more than in the brain, and therefore stimulation of the serotonin system primarily stimulates certain changes in the intestines. Therefore, let's say changes in the gastrointestinal tract are generally characteristic of selective serotonin reuptake inhibitors for all. Of course, escitalopram is no exception. And this can manifest as diarrhea, flatulence, decreased appetite, nausea, and similar manifestations. Next, the next side effect is sweating. Patients say they wake up in the morning and it's as if they could wring out their pillow or blanket, and even if it's not hot and it's winter or autumn weather, sweating will still be observed. And it turns out that when a person sweats, what desire arises when we sweat? To uncover. The person uncovers. But the room is cold. If it's cold, then they need to cover up. And once they cover up, they sweat even more. That is, the person may not be hot at all, but they will still sweat. Next, the next side effect is libido disturbance. But in fact, this disturbance is not as strong as with some other medications. And unlike other SSRIs, libido disturbances can resolve on their own within 1 to 2 months without any interventions. That is, you don't just start taking the medication as it happens, and all the while you're taking it, there will be libido disturbances. Most often still a week, 1 to 2 months, and libido is restored. Maybe not fully, but it will still be present. Well, if it doesn't help, there are many medications that help correct these libido disturbances. For example, mirtazapine, but in a very small dose. If the average dose of mirtazapine is 30 milligrams, here you can take 15 milligrams or even 7.5 milligrams. as doses for the antidepressant effect of this medication. These are very small doses, but for correcting libido disturbances, they are just right. There can also be weight loss or gain. Interestingly, it's 50-50. In some cases, there is weight gain. In others, there is no change or even weight loss. But the most interesting thing is that if weight gain occurs, it may not correlate with increased appetite. For example, when we talk about medications like mirtazapine, antidepressants, or when we talk about an antipsychotic like olanzapine, appetite increases. If you ask patients, they say they really want to eat. The person wakes up at night and wants a snack. But in this case, the person may not have an increased appetite, or it may even decrease. Yet the weight still increases. Something apparently changes in the biochemical processes. Sleep disturbance. On one hand, this medication can correct sleep disturbances because it is anti-anxiety, and anxiety causes sleep disturbances. But on the other hand, at certain stages, it can also cause sleep disturbances. Why does this happen? The fact is there is a certain balance in the brain between melatonin and serotonin. Serotonin is a natural antagonist of melatonin. When the level of serotonin increases, the level of melatonin can decrease. This disrupts falling asleep. This is the reason for insomnia that can occur when taking escitalopram. What is the conclusion? What needs to be done in this situation? Take the medication in the morning. That is why selective serotonin reuptake inhibitors are prescribed in the morning, not in the evening. Because sometimes they recommend, if the medication causes drowsiness, to take it in the evening. Well, it's fine when it's fine. But often when a person takes it in the evening, it starts to work differently. And it no longer causes drowsiness, but what does it cause? It causes, on the contrary, insomnia. Next, this medication, well, there are also certain positive aspects if we talk about side effects. It practically does not affect the cytochrome P450 system and therefore does not. It causes drug interactions. That is, accordingly, this medication can be mixed with other medications. This is especially relevant for older people. When people are already taking a certain number of medications, especially elderly people, and the number of medications can be both somatic and psychiatric, not only psychotropic. The somatic ones are quite numerous, and it's quite easy to encounter drug interactions, and in this regard it is quite safe as it does not affect this. It practically does not affect liver processes. Furthermore, nighttime leg twitching may occur. Why does it happen? We know that serotonin has a reciprocal interaction with dopamine to a certain extent. That is, what does it mean? The more serotonin, the less dopamine. And since the medication is very serotonergic, it is not surprising that it causes suppression of dopamine production through its effect on 5-HT2A receptors in the tuberoinfundibular zone. And we know that in the tuberoinfundibular zone, in the nigrostriatal zone, dopamine causes, or rather it blocks cholinergic interneurons. So when the dopamine blockade is removed, due to the decrease in dopamine, more acetylcholine is released. And what happens? These extrapyramidal disorders occur. And well, let's say these disorders, similar to restless leg syndrome, also occur due to a lack of dopamine. In essence, we can correct this problem, for example, with pregabalin or gabapentin, which block NMDA receptors, thus regulating the release of acetylcholine. Even this method can help us correct this side effect. Well, hair loss can also occur, but less frequently. The next side effect worth mentioning is cardiotoxicity, this notorious QT interval prolongation. But as a rule, this QT interval prolongation is not observed in all cases. The first is, of course, overdose. When we prescribe overdoses, when we prescribe doses higher than recommended in the instructions. When there is some influence on the metabolism of escitalopram, that is, some medications, and the level of escitalopram increases in the blood. That is, the patient takes the standard dose, but due to the influence of other medications, the concentration increases or the elimination of the medication decreases for certain reasons from the blood. Or accumulation of the medication due to certain drug interactions. This can also lead to QT interval prolongation. It is also not advisable to take medications that also prolong the QT interval. Citalopram prolongs the QT interval, another medication prolongs the QT interval, and the likelihood of side effects increases. You also need to be careful with patients who initially had a prolonged QT interval on the cardiogram. And therefore, to exclude such patients and be quite cautious with them, it would be good to do an electrocardiogram before starting treatment and see if the QT interval is prolonged. Then either use another medication or be quite cautious with prescribing especially high doses of escitalopram. Well, and with the intake of escitalopram, both tachycardia over 100 and bradycardia 50 and below beats per minute can occur. The next side effect that can be mentioned, which is quite common, is vision impairment. And I will immediately say that the cause of vision impairment when taking escitalopram is increased intraocular pressure. And what will be observed? Pupil dilation, mydriasis. And since the pupil is dilated, photophobia will occur. That is, in the light, the pupil should become narrow, but it does not. And it does not limit the penetration of light. And then it is easier for a person to see in a dimmer room. Then in a dimly lit room, a person sees more clearly. Their eyes hurt less than in the light, and people try to avoid bright light sources. Next, double vision may occur in the eyes, the so-called diplopia, and we must differentiate it in a certain way from psychosomatic double vision, which can also be present in similar patients whom we treat with escitalopram. And what test needs to be done? You need to close one eye, and that is if a person has increased intraocular pressure causing diplopia, then when the person closes one eye, the double vision will stop. But if a person has a psychosomatic disorder and they close one eye, the double vision will still be observed. Naturally, secondary manifestations as a result of vision impairment can be dizziness. That is, escitalopram itself as a rule does not cause such dizziness. But as a result of vision impairment, as a result of diplopia, secondary dizziness may occur. But if we increase the doses of escitalopram, then as a rule these vision impairments pass. Moreover, even if we then have to reduce the dose back, they will not reappear. But if increasing the dose did not help, we can simply use anti-glaucoma drops or seek help from an ophthalmologist. As for the timing of the onset of side effects, the side effect occurs either immediately after intake or occurs 3 hours after taking the medication, and they end after 2 to 3 weeks of taking the medication. They are almost all transient, and therefore they should not greatly concern us. Of course, to improve the patient's quality of life, we can correct these side effects. But sometimes, frankly, patients do not even report them. They just endure them and they go away. And patients continue to take the medication successfully. What should alert us when side effects last more than 3 weeks? When side effects last more than a month. This indicates that these are no longer transient side effects, but that the medication has affected some exacerbated, aroused. How is it? Awakened some pathology, which was perhaps, that is, in such remission, and the medication activated it. Then it is necessary to examine the patient and correct the side effects, or make a decision to switch to another medication. Next, what is the treatment dynamics? As a rule, the medication reveals itself no earlier than after 1.5 months, but it is worth aiming even for 3 months. Most likely it will reveal itself in 1.5 to 2 months, but it will definitely reveal itself in 3 months. Why do I mention the 3rd month? Because we should not give false hope to the patient. If we say that the medication will reveal itself in 3 months and it reveals itself in 1.5 months, then nothing bad will happen. But if we say that the medication should reveal itself in 1.5 months and it reveals itself in 3 months, the patient will stop taking it after 2 months. Yes, so let's aim for 3 months. But let's keep in mind that 1.5 to 2 months is just such a period. Until the medication reveals itself, certain swings in the improvement of the condition may be observed. That is, you cannot say that the patient takes the medication for 3 months and then click and the medication worked. Of course, during this period of time, there will be improvements and improvements. After 3 months, we will not notice improvements, but the medication will fully reveal itself. And we will notice improvements in 2 weeks, and in 3 weeks, we will already be observing them. So sometimes it happens that improvements start to appear very quickly, especially the anti-anxiety effects. Sometimes literally in the first week, patients experience it, and then it gets worse. Then better again, then worse again. And sometimes on such a wave, when it got better, and then it seemed to get worse, the patient says the medication stopped working. And it's good if they come and tell the doctor that the medication stopped working. But if they just stop taking it and no longer come to their doctor, but go to another doctor, and the other doctor prescribes something else, yes, separately says, yes, indeed, this medication does not work. That is, this needs to be warned about, and then the patient, as they say, if informed, means armed. That is, they perfectly understand that the first improvements in the first weeks do not mean that they will still be quite stable. But even after 3 months, when the medication has fully revealed itself, sometimes there may be so-called setbacks. That is, when the condition seems to return a little to the previous one, which was before treatment. But as a rule, these setbacks are caused by some stresses, and stresses can be not only psychological, but also somatic. Let's recall Celia's theory, the theory of stress. Any impacts, even somatic, viral, for example, infections, other infections, are also stress for the body, and they can provoke a setback in the condition. But as a rule, then within literally 1 day, 2 days, everything is restored, and then the person should feel good. That is, it is clear if a person took medications, they stopped working, and we do not observe the effect for a month, then, well, it is worth considering. But if patients complain that for a couple of days, suddenly they ran, oh, doctor, the medication stopped working, this does not mean anything yet. That is, we can simply say either wait or get away with some cliché that will calm the patient a little, but the next day they will already feel significantly better. Next, it is worth moving on to dosages. It should be noted that the calculation based on body weight of this medication does not matter. Body weight does not affect the dose of the medication. Sensitivity to it is determined by other processes. Therefore, the dose can be the same for a person who weighs 60 kilograms and for a person who weighs 120 kilograms. There is no need to prescribe twice the dose. The standard starting dose is 10 milligrams. That is the minimum dose in which the medication is available. And then we need to evaluate its effect, these 10 milligrams, in 3 to 4 weeks, not in 2 weeks, as with some other medications. A little longer, in 3 to 4 weeks, and then we look at the effectiveness and adjust the dose. But we should not do this when a person has taken it for another week, 2 weeks. Here we start to increase the dose, decrease the dose, increase the dose, decrease the dose. Increased side effects appeared, decreased, some effectiveness disappeared. No need to rush. The medication has not yet started working. There is no point in rushing in this regard. Therefore, we stay on this dose. And then in 3 to 4 weeks, we look and, if necessary, increase the dose by 5 milligrams per week. And so, if necessary, we increase it to the maximum dose of 20 milligrams per day. We stop increasing if the symptoms disappear. That is, it will also be a mistake when we see that the symptoms have disappeared, but we do not. We still increase to 20 milligrams. That would also be wrong. On the other hand, what else should we pay attention to? We increased the dose, looked, it seems the dose is effective. Maybe it's worth stopping at the dose. I'll tell you a little trick. If you somehow provoke the patient, well, say something negative to them in some way. Cause them stress, cause them a situation of confusion. And if the person reacted in some way, it means that the doses are small. It means the dose needs to be increased. It means that this dose is insufficient. It is better for the doctor to provoke them in this way than for the surrounding world to provoke them in this way, because the doctor can adjust the dose. And when the environment does it, the person does not know what to do in this situation. What should we focus on when selecting doses? On two components. If the dose is insufficient, it means that anxiety will manifest. That is the preservation of anxiety, not necessarily manifestation, but preservation of anxiety if we prescribe to anxious patients. If it persists, it means the dose is insufficient. The dose needs to be increased. But if apathy appears, which we described, it means the dose is too high. And how can it manifest? This is instead of calmness, because often people cannot understand what apathy is and what is the effect of the medication. Maybe this is how the medication should work, maybe this is such an effect and it does not suit me. And therefore, let's draw a small certain boundary. What does a person expect from the medication? It is calmness and joy. And instead of calmness and joy, they get drowsiness, they get lethargy, they get weakness, deterioration of cognitive functions, lack of emotional reaction to the surrounding world. And this does not mean that the medication did not suit them. Not that probably I should not have, I did not need this. I needed, this is not needed by anyone. No patient. This does not mean that the medication was chosen incorrectly. It means that we have reached too high doses. And in such a situation, what needs to be done? Reduce the dose a little by 2.5 milligrams and then wait 2 weeks. If necessary, in 2 weeks, we can again increase by 2.5 milligrams. Again, suppose a reduction by 2.5 milligrams did not lead to an effect. For example, the person was taking 20 milligrams, we reduced it, they have 17.5 milligrams. So, we see apathy still persists after a couple of days reduced to 15 milligrams. Oh, apathy is gone. All right, we observe for a certain time. Everything is fine, no problems, but there is not enough full effect from the medication. Again, increase the dose by 2.5 milligrams. If necessary, again by 2.5 milligrams. Again, apathy appeared. Again, at this stage, you can move forward and backward. That is, until the medication has revealed itself, this should not be done. The medication is taken once a day. Why? Because the half-life is 30 hours, which is more than enough not to split the dose of the medication. And as a rule, rarely does anyone have to, due to side effects, split it. Completely, as we said, the medication reveals itself in 3 months. But what should be paid attention to? The longer a person has been ill, we talked about this, but I will emphasize again, the longer you have to wait for the medication to reveal itself. There is such a situation with my patients. When patients come and say for the first time, literally 3 weeks, a month, and the medication revealed itself and felt so wonderful, as if the mood immediately changed, immediately wanted to do something, the medication caused some kind of confidence, and here I have been taking it for 2 months, and there is no effect. Well, sorry, the person has been ill for 2 years, 3 years have passed since the moment when they first had this problem. Moreover, they have already been treated with the medication. There is a certain tolerance to the medication. That is nothing terrible. You just need to take the medication a little longer. What else needs to be said? If we are dealing not so much with depressive as with anxious patients, and this anxious component is pronounced, and this anxious component increases significantly when increasing doses of medications, or even with the first dose, for example, 10 milligrams, or we understand that the patient is very anxious, and in general, this is quite a high dose, we can prescribe a very small dose, a quarter of a tablet, that is 2.5 milligrams, and then every 3 to 4 days, once a week, we can increase the dose by 2.5 milligrams. That is, it was 2.5 milligrams, prescribed after a week already 5 milligrams. Not plus 5, but brought to 5. Then another 2.5. But still, the dose needs to be brought to at least 10 milligrams. The therapeutic window in which the medication works. The therapeutic window is 10 to 20 milligrams. If we do not fall into this window, there will be no effect. I ask you to remember this, because many patients start to feel some effects already at a dose of 5 milligrams. And they say, well, excellent, everything, the medication worked, I do not need to increase. And they deceive the doctor. They say, yes, doctor, we are taking such medications. And then they might have read some incorrect forms or consulted with someone, for example, other patients. Ultimately, it turns out that the person didn't reach the normal dose, takes it for a month or two, then calls and says, I've had a flare-up, the medication isn't helping, everything's back to how it was before. That is, there was some minor stress, some provocation occurred, like catching a viral illness, and now everything's bad again. It's become bad because the person hasn't entered the therapeutic window. At these doses, the effect is extremely unstable. You can't feel the full effectiveness of this medication. Next. For the elderly, doses should be slightly lower. We won't dwell on this now. We have an entire program dedicated to dementia and cognitive impairments. We'll just say that for elderly people, it's not advisable to go above 10 milligrams. The dose will fluctuate between 5 and 10 milligrams. For them, the therapeutic window will be slightly shifted downwards. This is because due to certain breakdowns of the medication and metabolic processes, the medication is disrupted in people. The sensitivity to the medication changes. So let's just remember that doses will fluctuate from 5 to 10 milligrams. For the elderly or rather older people, it's better not to increase doses to 120 milligrams. How do we discontinue the medication? Well, often the medication is very easy to discontinue. Patients even stop from high doses of 20 milligrams all at once without any problems. But especially if patients reduce the medication gradually, side effects are extremely rare, and just when discontinuing the medication, it's rare. Well, it's very rare, but if even tapering doesn't help, that is, gradually reducing, say, by 2.5 milligrams. Even if that doesn't help, then some doctors, well, I haven't had to deal with this. Some doctors use this scheme. For example, a person was taking 20 milligrams. They try to reduce to 15 milligrams. Symptoms worsen. Then they do this. For example, on Monday, they take 20 milligrams. On Tuesday, 15 milligrams. On Wednesday, 20 milligrams. On Thursday, 15 milligrams. On Friday, 20. On Saturday, 15 milligrams. So, well, fluctuations. That's it. Then a week passes with these fluctuations. And the next week, the person takes 15 milligrams all the time, stabilizes. Then they took 15, take 15 one day 13.5, 12.5, 15, 12.5, and so on and so on. They taper off. But again, I'll repeat that with escitalopram, withdrawal syndrome is quite rare, and therefore it's rarely necessary to resort to this. Now, what combinations are possible? Combining escitalopram with lamotrigine sometimes allows us to overcome apathy that may occur when taking this medication. You can't combine medications with selective serotonin reuptake inhibitors with selective serotonin and norepinephrine reuptake inhibitors. Now, sometimes this logic arises. Weak, mild medications with escitalopram. A more powerful medication, for example, venlafaxine, I'll adjust, add norepinephrine. But we mustn't forget that selective serotonin and norepinephrine reuptake inhibitors affect both serotonin and norepinephrine, not just selective norepinephrine reuptake inhibitors. Therefore, if you make such a combination, you'll enhance not only the noradrenergic effect, but also significantly add the serotonergic component, which can lead to serotonin syndrome. You need to be cautious when taking it with anticoagulants, including non-steroidal anti-inflammatory drugs, especially in patients who have had bleeding in their history. For example, gastric bleeding, bleeding from varices. This can lead to reduced blood clotting and the occurrence of bleeding. You need to be cautious when taking the medication with NSAIDs due to the possibility of undesirable gastrointestinal side effects. For example, the potential ulcerogenic effect of this medication. Therefore, it's necessary to add proton pump inhibitors. A few words should also be said about citalopram. Since the medications are quite similar, but also have many similarities, therefore I don't see the point in dedicating a separate lecture to escitalopram. So, we'll talk just a few words, let's say, within this lecture about escitalopram, and here we should recall the theory of stereoisomerism. There are such molecules that represent an absolutely identical molecule, but there are molecules with one structure. The configuration of these molecules is different, like the right and left hand. That is, they are identical, but they are completely like mirror images of each other. Just like that, molecules in medications, in other substances in particular, can be twisted in different directions. That is a completely identical formula, but there is an S isomer. This is the left isomer which rotates the passing light to the left, a left rotating isomer, and there is an R isomer which rotates to the right. And it turned out that even a Nobel Prize was awarded for this, a very important invention. So it turned out that the effectiveness of each of the structural elements is different. And that's exactly what happens with citalopram and escitalopram. If citalopram contains both isomers, both R and S, both right and left rotating, but in escitalopram only the left rotating, only active, and the inactive R is discarded. But in citalopram there is both. That is less selective, and therefore accordingly the doses of citalopram will be half dose of citalopram. What does the S isomer give us? It's the absence of an antihistamine effect. Accordingly, since there is no antihistamine effect, there is less drowsiness and less increase in appetite. There are no dose-dependent restrictions in terms of increasing the QT interval. Predictability of effects at high doses. Pure inhibition mainly only of serotonin receptors, greater safety and no influence on the cytochrome P450 system. Therefore, it can be more easily combined with other medications. Naturally, this same isomer is also contained in citalopram. Only in addition to this isomer, 50% of the medication consists of what? The R isomer. That is, which seems unnecessary to us. But what does the R isomer give us? The R isomer practically does not affect depressive symptoms, but it gives mild antihistamine properties. But these mild antihistamine properties are hundreds of times, for example, weaker than those of amitriptyline and even mirtazapine. Hundreds of times weaker. Therefore, it is said that this bad isomer causes blockade of histamine receptors. Well, blockade is blockade, but it is extremely minimal. Next, increasing the QT interval. Well, this is true. It is less safe in terms of cardiological side effects, especially at high doses, especially at overdoses, which exceed the recommended doses in the instructions. At low doses, this isomer will have no effect at all, and it is considered that the R isomer hinders the effect of the S isomer. So these are all the differences. They also differ from escitalopram in their effect on norepinephrine, but we know that both medications are very selective in their effect on serotonin, and there's practically nothing to latch on to. But in principle, there is such data that if we say that the escitalopram ratio of influence on serotonin to norepinephrine is 1 to 7,000, then citalopram's ratio of influence on serotonin to norepinephrine is 1 to 4,000. But still, it's 1 to 1,000. These thousands practically have no effect. So formally, yes, this fact exists, but these are, roughly speaking, data pulled out of thin air, which have no clinical significance, in my opinion. Therefore, the difference between the medications is extremely insignificant. Well, what can be said? That on the one hand, citalopram acts, in my opinion, if practically a little softer when starting the medication. There are potential exacerbations of anxiety, for example. Well, it acts softer, but takes longer to unfold. And citalopram takes a long time to unfold. Citalopram can take even longer to unfold. What can be said is that citalopram, in my opinion, is a little stronger in action at adequate doses. It causes a little more calmness. We mentioned that there is less initial anxiety. It can be noted that the more severe the depression, the higher the effectiveness of citalopram compared to citalopram. That is, if we see a more severe condition, then it's better to give preference to citalopram rather than citalopram. In terms of side effects, their main difference is still the minimal influence on histamine receptors. But again, as we said, it is hundreds of times less than tricyclics. This influence, although, as they say, to be fair, let's say that, for example, if we talk about fluoxetine, it has even less influence on histamine receptors. Well, the histamine receptor is drowsiness. It's an increase in appetite, especially for carbohydrates. Dosing. Well, as we said, since there is this right isomer, like a bad isomer, that is, half of this medication is bad, as it were, unnecessary. So the doses of citalopram are twice as high as those of escitalopram. If, for example, the initial dose of escitalopram was 10 milligrams, then here it will be 20 milligrams, and the maximum dose will be 60 milligrams. But in principle, this window will be 20 to 40 milligrams. Well, and it's better to start when prescribing half the medication. I mean, a quarter, half. That is not 20 milligrams immediately, but 10 milligrams. And then after 4 days, we enter the therapeutic window, 20 milligrams. Well, and then everything is exactly the same as with the citalopram. That's all I wanted to say today. Thank you for your attention.